Thank you. If we could have report of the action taken in closed session by our legal counsel.
Certainly. First, the board met in closed session with its real property negotiator pursuant to Government Code Section 54956.8 with the district's negotiator, Louis Ward, regarding the price and terms of payment to be negotiated with Coyote Rock 2023 LLC for the property identified as APN 019650007. No reportable action was taken. Second, the board considered approving the closed session minutes for the regular meeting held on November 21st, 2024, the special meeting held at 1:30 p.m. on December 11th, 2024, the special meeting held at 4 p.m. on December 11th, 2024, the special meeting held on December 12th, 2024, and the special meeting held on December 13th, 2024, and the board voted unanimously to approve those closed session minutes as presented. Third, the board considered a public employee performance evaluation pursuant to Government Code Section 54957. No reportable action was taken. And last, the board held a hearing pursuant to Health and Safety Code Section 32155 to consider medical staff credentials, and the board voted unanimously to approve the medical staff credentials as presented.
Thank you so much for that. Item 9 is a deletion or correction to the posted agenda. Are there any deletions or corrections that the board would like to make? Any deletions or corrections from the staff or audience? Okay, if not, then we'll move on to item 10. It's input from our audience, and this is an opportunity for the public to speak to the board on any item they choose that is not on the agenda. And you have 3 minutes to present something to the board. And again, it's not covered by the Brown Act because it was not agendized, but we certainly will take into consideration anything that the public wants to tell us. So do I have any audience input? If you'd give your name for the record, that would be great, even though we know your name.
I'm sure you do by now. Hi, my name is Meg Heim. I am with the North Tahoe chapter of Citizens Climate Lobby. It's good to see all of you again. I wanted to use my public comment tonight to first welcome Dr. Rob onto the board. We're really excited for you to join this group and to help foster more community engagement and dialogue with members of our collective community that want to help improve the hospital in various ways. Also on the leadership front, we're really looking forward to hearing about the new CEO whenever that hiring decision has been finalized. We'd love the opportunity to meet with her or him and to share our perspective and ideas for how we believe the hospital can improve its level of sustainability and its commitment to educating itself about the health effects of climate change and sharing that knowledge with patients. From our viewpoint, the prior CEO was not someone who cared about the health of, or who cared about climate change or how it affected the health of our community. So we're really looking forward to having a hospital leader who we hope will be interested in this issue and who can help create some momentum on the sustainability work that's already been started, like the greenhouse gas inventory. So we look forward to hearing more and to that future announcement. Thank you.
Thank you so much, Meg. And again, you will know something as soon as we know something. Any others who have?
Good evening. For the record, my name is Deirdre Henderson. I'm the co-leader of the North Tahoe chapter of Citizens Climate Lobby and also the co-leader of 100% Renewable Truckee. So first, I'd also like to welcome Dr. Rob to the Tahoe Forest Board. You'll get used to seeing us a lot at these meetings. And now I'd like to take a minute to look into the year 2025. As Meg mentioned, we are very much looking forward to the appointment of a new CEO. As you know, in the past, we have sponsored 2 community presentations, 2 in the past 3 years. featuring regionally and nationally known doctors with this special expertise in the health effects of climate change. We invited Tahoe Forest to co-sponsor those with us, along with the town of Truckee, which is co-sponsored, Sierra Business Council, Sierra Community House, and others, and Tahoe Forest declined. Frankly, we found this confounding, and we look forward to regime change and a more open attitude toward meaningful community interaction. We also believe, as has been commented at past meetings, that Tahoe Forest needs to be more active in educating our patient population on the health effects of climate change. And we look forward to a conversation with you about how we can remedy this. On a very positive note, we are very pleased that you completed the 2024 greenhouse gas emissions inventory with Mazzetti. Thank you, Louis Ward. We now look forward to adding to that first necessary step a climate action plan. The greenhouse gas inventory is only valuable if you act on it with climate goals and metrics and timelines. So let's get some return on that initial investment. And we want to express our gratitude that at long last you have joined the Climate Transformation Alliance, and we hope that this will activate even more commitment to sustainability and climate action. And finally, I wish you all happy holidays and best wishes for a productive and collaborative and less stressful New Year. Thank you.
Thank you, Deirdre, and we do hope to be able to give you more information on what we are going to be doing. I know that we've got some initiatives in place within the hospital that we're working on, and when we have some.
I heard about one a few minutes ago.
Okay, great.
Very good.
Yeah.
Really nice.
And thank you for your consistent coming to our meetings and reminding us of what we should be doing. So thank you again. Any other comments by our audience? Okay. If there's no more comments, I will go on to 11, input from the Employee Association. And we have Julie here.
Put my readers on. All right. Good evening. For those of you who don't know me, my name is Julie Morgan. I'm an ER nurse. I've worked here in the emergency department for coming up on 17 years now. I'm also the president of the Employees Association of Professionals, which is our union affiliation. I'd like to start by saying thank you for this time to address the board and by welcoming Dr. Darson-Kavich to the board. It will be nice to have your smiling, shiny new face at these meetings, and we look forward to your input as well as we move forward into 2025, the selection and seating of our new CEO and the future of our district. Welcome. As president of the union, I believe the union board is in a unique situation. We interact with many different employees from multiple departments on a variety of issues. We coordinate and work with management on employee issues, concerns, complaints, as well as ideas and suggestions. We often work to bridge the gap between management and our everyday boots on the ground employees. We try to be the voice of the people, to listen, interpret, investigate, and then negotiate as needed. Throughout Ask Me International, I've heard horror stories of breakdowns in communication, outright poor relations between employees and management, attorneys involved, walkouts, delays in contract negotiation, and outright screaming matches. We as the EAP board feel incredibly grateful for our amazing mountain town, our community, and the healthy relationship we have built with the management team at Tahoe Forest Hospital. As most of you are aware, our current contract is set to expire on June 30th of 25. We will begin negotiations on the new contract starting February 1st of 2025. We look forward to working with management, Alex and Lauren, to create a contract that is both fiscally responsible while looking toward our future and providing the absolute best working environment for our employees. We truly are the best mountain healthcare facility in the country, and it falls to each and every one of us to ensure that that's where the truth lies. In previous meetings, I've expressed the desire of our employees to be more included in the future of our district. We have discussed the values that comes from listening to the concerns, the ideas, and opinions of those who do the everyday work of the district. Those employees who make sure the snow is shoveled. The shelves are stocked. The patients are tucked in and cared for. The smiling receptionists who greet our patients and alleviate their stress. And whoever it is that makes our computers work when they rise up against us, those people. I'd like to take this opportunity to say again, the future is us, all of us. We must move into 25 as a team. I realize that C-suite and management deal with issues which we may never fully understand, but the employees, the staff, the workers, we too deal every day with situations that management might never really realize or fully understand. This community and our patients deserve for us to work as a team to value and listen to one another. I would like to propose to the board, consider creating a position, a trustee maybe, an advisor, to assist them with understanding the issues at the employee level. I'm unsure if this is even feasible, but I am sure that we will be stronger as a district if our employees are completely invested, and in order to be invested, they need to feel that they are heard and valued. Listening is free, but it's so incredibly powerful. We must learn to see the value in others so clearly that they come to see it in themselves. I thank you for your time and for listening to me. Have a great night.
Thank you very much, Julie. And again, to our employees, that we do realize and recognize their contribution to the organization. And thank you for bringing that to us. Our next item is item 12, items for board discussion. And I'd like to have our former director, Robert Barnett, join me at the microphone. It's like old times, Bob, except that we're on this side of the,
Right.
rather than on that side. But again, we want to express our gratitude to you through a proclamation. And I'd like to read that to you now. Whereas the Tahoe Forest Hospital District is a hospital district duly organized and existing under the local healthcare district law of the state of California. And whereas the Tahoe Forest Hospital District Board of Directors in October 2021 desired to fill a board vacancy by appointment and initiated a public application and interview process to appoint a new director. And whereas on September 28, 2021, by unanimous vote of the Board of Directors, appointed Robert Barnett to serve as a director. And whereas Director Barnett, in November of 2022, stood before election and was duly elected to serve the remainder of the term in which he was seated. And whereas Director Barnett added to the diversity and board viewpoints and discussion, given his 45-year legal practice, which included extensive medical legal work. And whereas Director Barnett actively served on the Governance Committee and the Quality Committee, where his contribution to improvement and efficiencies were greatly appreciated and adopted by the full board. And whereas Director Barnett demonstrated a dedicated interest in what was best practice for the hospital and the staff, and what was in the particular interest for the public we serve. And now, therefore, be it proclaimed by the chairperson of the Tahoe Forest Hospital District, a most sincere gratitude and appreciation to Director Robert Barnett for his unwavering service to the community, patients, and staff. And we wish him well in all his future endeavors. And something to remember us by, a plaque reminding you of how grateful we are for the service that you provided. Thank you.
Wow, thank you so much. Well, you know me well enough to know I have a few things to say.
And he knows to only have 3 minutes.
3 minutes. First of all, I want to congratulate Dr. Rob on his being elected to the board, and on Alice for her reelection. And I want to say thank you to each board member and acknowledge special things about them. I want to start with Alice by saying very few people understand how much time is put into being both a board member and an officer on the board. Alice's dedication is amazing. It's like a full-time job that she took on. I think everybody should understand how much time it takes to be a board member. I think I had somewhere between 150 and 170 meetings in the 3 years that I was on the board. And I want to acknowledge Director Michael McGeary, because he's a man of passion for all things healthcare, and he has introduced community as one of our mountaintop aspirations and help us focus on that. So, Michael, it's been great working with you. I also have to say, Mary Brown, who spent most of her adult life on hospital boards, has always provided a useful perspective on all the issues that we tackled, and I know your dad would appreciate what you've done. Finally, I have to say to Dale Champlin, who was kind of my mentor in this process, I really appreciate what you added to my life in practicing on this board, and also, you know, more than a decade of service to this hospital. I mean, this is really outstanding what this board does. And I just want to take a quick moment to kind of go through what we encountered in the last 3 years. We started with COVID, then we had rapid growth, then we had burnout, and then we changed our focus from growth to community, and then we started working on solutions to access, and we introduced management systems, we introduced dyadic relationships, and in this process, a new Chief Medical Officer came in and worked his hardest to improve this hospital. We also had a new Chief Operating Officer who came in, put his roots in this community, and did everything he possibly could to make this hospital a better place to work in. Also, I just want to say something about the people who work in this hospital. There were so many physicians and other healthcare providers that contacted me while I was on the board that had the best interest of this hospital in their heart. And there were leadership issues that we addressed and tried to refocus on a collaborative approach. So I just want to say that in the process of 3 years on this board, working with outstanding people, one of the things that stands out is the civility of this board. In all of these meetings, and we didn't agree on everything, and I have to say, not one person said anything that was impolite, not one person ever denigrated anyone else, not one person ever made a snide or impolite remark, and through all the issues that we covered, everybody had a chance to listen to everyone else. And there was always an effort to come together and find the best solution. And I think that standard of civility is something that going forward should be repeated across the governments in this country, because that's the way it should work. So finally, the thing I want to say is that we have an extraordinary healthcare community with extraordinary people in it, and it's been a privilege to serve you. Thank you.
Glasses.
Glasses. Oh, great, thank you.
Bob, wait.
Glasses.
Whoops, yeah, that'll help.
You'll get home without them.
Way home.
And after that, we'll move to 14.2. We have Dr. Reichert and I guess Kelly.
Kelly is not able to make it tonight.
Okay.
Alice, the feedback is first.
Oh, I'm sorry. I got you too early.
Just a second, Dr. White. One right in front of you.
Yep. I missed it. 14.1 is our Patient and Family Advisory Council presentation.
Did we do consent calendar?
I'm sorry?
Did we do the consent
Consent calendar.
13?
Boy, that really threw me, didn't it?
Yeah,
Okay.
we could probably do that very quickly.
Yeah, so we have 13 while they're getting themselves organized. And this is the consent calendar that usually has reports, minutes, policies that have been reviewed already, and we can pull anything that you would like to have further discussion on. Is anything from the board that might?
I have nothing.
Okay.
Can we do this? Oh wait, that's different than yours.
You're in the minutes. Anything from our staff that they would wish to pull? Any comments from our audience? All right, then can I have a motion to approve the consent calendar as presented?
So moved, Dale.
Can I have a second, please?
Second?
Okay, so it's been moved and seconded to approve the consent calendar as presented. All in favor?
Aye.
All opposed? So the consent calendar is approved as presented. Now we're going to get back on track. I know where I am on this agenda, and it's for items for board discussion. And our Patient and Family Advisory Council, Alex Crone and Karina Toledo, one of the members of PFAC, are here to present. So thank you.
All right, thank you for giving us this opportunity to share our accomplishments of our Patient Family Advisory Council, or for hereforth PFAC, just to make it shorter. I'm Alex Crone. I'm the Clinical Patient Experience Specialist. I help oversee patient satisfaction, and I help manage complaints at the hospital. But also, one of my other parts of my job is helping facilitate this awesome group. So some of the accomplishments that we had this year is that we added 3 new members, which is pretty big for us. So Jane, Amber, and Sharon all joined this year, and we have one more onboarding currently right now. So hopefully we'll be joining for 2025. We had 5 departments presenting to the board, to the council for the first time. One technically hadn't been for 5 years, but we considered them new. And we were the first members of the public to learn about all the new project developments with Rite Aid, Gateway, and Tahoe City. So that was pretty exciting for everybody. So some of the first-time presenter departments were marketing, behavioral health, facilities and construction, labor delivery, and our skilled nursing and extended care center. We continue to provide input for improvements, for signs to disruptive patient behavior. We will summarize all of our topics in a second here. Media and marketing campaigns, modes for marketing and communication, and senior citizen services and resources, and ways to address some of our difficult complaints that come through the system. So just to summarize kind of what we did this year, we meet 9 times out of the year on a monthly basis. We skip the months of July, August, and December. So for January, we kicked off the year with a lot of patient interaction focused topics. We introduced the concept of a secret shopper program to help address some customer service issues. We gave input on disruptive patient agreements and policy as a result of some increased issues with disruptive patients throughout the health system and how to manage them, and suggested a de-escalation training for all staff to be considered. In February,
So in February, we were joined, and I'm Karina Toledo. I've been on PFAC member since 2022, and 20-year Truckee resident, though, and excited to be part of this committee and program. So in February, we are joined by Jonathan Lowe, a behavioral health provider who presented to the board regarding his use of Spravato, aka esketamine treatment for chronic depression. And, you know, esketamine is the first FDA-approved psychedelic treatment, so obviously there's a little bit of time to get this embraced by the broader medical system. So he did cite really excellent patient success rate with treatment-resistant depression. So at the time of the meeting, he had implemented 750 treatments so far. He did express some challenges, including lack of a buy and bill system, which would allow us to collect better reimbursement. So because we don't stock esketamine at the pharmacies, we have to work with specialized pharmacies in other states outside of our healthcare system, which obviously is an impediment to care. Also, the conversation around behavioral health really brought up just the broader needs that the hospital system has and the community needs for more therapists, expanded services, including group therapy. So obviously, that is something on the future agenda that we will be revisiting.
So in March, we had Heather Hiller, one of my colleagues in quality and regulations, come and discuss just to increase the community awareness of sepsis and educating the public. We wanted to introduce that, you know, sepsis is one of the leading cause of hospital readmissions, and all the great implementations that Tahoe Forest is incorporated with bundles, in the multidisciplinary sepsis committee, and all these things that we're doing to help improve our core measures and track all of our sepsis measures. Sorry. Yep. Go ahead, April.
Here, I don't want to switch to April. So for April, we actually had our very own Alex Crone present to review our patient satisfaction scores from Press Ganey for our main service line. So we know we actually have really high patient satisfaction scores through Press Ganey when you compare us to the national average, but we did review trends and changes that had occurred over the past couple of years, and we also, evaluated the entire survey process, reviewed many of the questions asked on surveys, and really looked at potential factors and explanations related to the trends and changes that we saw over the past couple of years. We also discussed how the scores and comments were shared with leadership and giving them opportunities for improvement, whether that's working with practitioners individually or in departments. There were some great examples when we reviewed the trends of opportunities that we had based on the feedback where leadership implemented those changes and we saw our scores go up. So it's nice to see it in action. We also it gave us the opportunity to really discuss whether or not we were gathering, a broad range of feedback or whether or not we were just kind of pooling from people that had really positive feedback. So it brought up the conversation of making sure that we were, putting things like posters in offices to make sure to engage with patients every opportunity to get a range of feedback. There was also an example of myself personally. I had been to the urgent care and didn't receive a survey, so I brought that to Alex's attention and she immediately followed up, and within a couple of days we realized that there was a gap in that, so it was nice to have kind of eyes on the ground when there is challenges with the survey system. And then we also have one of our members recommend exploring the use of AI like ChatGPT to organize feedback and really identify, immediate trends that we can take action on more immediately. So beneficial overall.
In May, we had Ellie, our manager of labor and delivery, and she introduced some doula services. She was hoping to maybe get some buy-in and some community outreach to the community to see if there was an interest in introducing a doula services in Tahoe Forest. Those not familiar with doulas, they're non-medical professionals who provide guidance and support throughout pregnancy and labor and delivery, and especially for a rural hospital like us, it could be something that would be really beneficial. So our objective was just to see if perhaps there was interest in the community. How can we get the word out there, and how do we increase interest in this possible program in the future?
For June, we are joined by Meg Rabb, our Director of Marketing and Advertising, alongside Ted Owens, our Executive Director of Governance and Business Development. So they came to join us to really gather input regarding general marketing and advertising ideas for the near and distant future. And essentially the goal was to re-engage our community, and they were looking for feedback in general around current branding and perception of the hospital within our community, and to basically guide some of the messaging and mode of communication. They did bring some initiatives that they were interested in pursuing regarding kind of marketing services to people that were second homeowners that were here, on occasion through the summer or through the winter. And it did, spur the conversation that, our PFAC recommended that we really focus in on advertising where we have more capacity. So focusing in on things like urgent care, emergency department, because there has been this kind of repeated challenge that occurs where there's limited access to care regarding primary services, primary care services, and primary physician access. So we wanted to make sure that the perception from the community wasn't that we were trying to bring in, new out-of-towners to the primary care that could limit their access. So that was one of our suggestions, and then they did return after the summer to review some more in October.
In September, Dylan Crosby, who you know well, our VP of Facilities and Construction, was nice enough to come to the group to update on future construction projects. We hear about the Rite Aid building and the Gateway building, but he actually was able to provide us with an update as to what those actual future plans were and how they will impact patient access going into the future. Patient access has been a huge topic of interest for the community and for this group. So we wanted to help show how we're going to improve the patient access and expand and update our facilities.
So in October, Meg Rabb and Ted Owens joined us again to kind of review some of the, update us on current projects and review some of the marketing campaigns. Ted specifically presented to the board around 2 different healthcare bills that have recently gone through the California legislature to discuss how they could affect and how they, would affect our current care regarding essentially improving access to care. And so he informed the group of the potential impacts of that with the proposed legislation. And then Meg presented on the different media campaigns that have been implemented since our discussion in June. Specifically, a really incredible video was showcased regarding Tahoe Forest's 75th anniversary that did feature a lot of local employees. That was one of the feedback that came out of June, was that, a lot of people in our community wanted to see real people versus, actors or models on advertising. So that was a neat engagement project that got a lot of good feedback. And also, we talked about the e-newsletters that are available for various service lines on our website. And it gave us the opportunity to kind of sign up for them in real time and test out to make sure that response was working, and also just discuss, other opportunities for e-newsletters with like pediatric care, for example. And also there was discussion around social media, which apparently engagement via social media has improved significantly over the last year. And so Meg discussed how this will be a continued focus for us in the community. There was some discussion around platforms like LinkedIn that also reaches, more of a business platform that could essentially leverage opportunities to bring in more employees as well, not just marketing towards patients.
And then lastly, last month, Maggie Abrams, she's our Director of Distinct Part Skilled Nursing Facility. She introduced the Skilled Nursing Facility and ECC to the group. Again, another part of Tahoe Forest that I think a lot of people maybe didn't know existed, and helped inform the group of the admission process of admission, and also through this group, we were able to provide some input on how to help streamline care for the residents. We noticed a little bit of a gap when it was coming to residents being able to actually get to their appointments, and having an escort with them. So through this, we were actually able to start a conversation and implemented a little process change where now residents, when they're going to their outpatient and specialist appointments, will be escorted with a family member. So that will just help kind of streamline their care and handoffs. So that was kind of our year. We had a lot of topics that we discussed.
So Alex, can you tell us a little bit more of what you learned from the secret shopper that you didn't know or we didn't have data on?
Yeah, we weren't able to really form it into a official program yet, because we had some difficulty in trying to figure out how do we implement this. Do we take people with existing appointments and just kind of randomly select them to try to get them to fill out a form with some objective questions? We weren't able to really develop it, so it's still something that we've tabled, but we want to revisit. So I mean, the point is that we want to increase, especially our registration. That first point of contact with patients, they're the kind of the face of the patient experience throughout that rest of the day. So how do we get those scores to make sure that they're always being met with a friendly face, someone who's going to be very courteous, respectful, and very helpful, and just make sure that we have that expectation every time.
And so what couldn't you figure out in terms of taking up time or taking up access, or, because I can think of a couple ways other organizations and not healthcare do it. And so I wondered if you were going to continue to try to work on something.
I think the challenge we came to was when it came to incentive and what are the implications, if they don't perform as expected, or there's something of constructive criticism, what will that mean for them in performance, or, is there incentive that we can build in? Well, we kind of want that to happen all the time. We want them to be friendly, so we didn't feel like it was appropriate necessarily especially with HR consult as well, to do a reward system. Because again, it's kind of the expectation in the culture. We also wanted to try to find, how do we have an objective, systematic list of highlights, things that need to be done every time. Had difficulty in coming up with something like that. So it hasn't been scrapped, but I guess it just hasn't been fully developed.
Yeah.
But I'd like to.
Yeah, I was
The
going to say, it's
ideas-
a great idea.
Yeah, it's still in the idea phase, right? I think that we can get it there. It's just, it sounds like there needs to be some additional conversations and, something we're willing to absolutely look into next year and see where we come up with.
As just like a qualitative report, I've had some PFAC members have appointments at various areas and come back to me and tell me just how their experience was overall. So.
And if you just put it out to the organization that you're going to have secret shoppers, they're not going to know if there aren't any secret shoppers. But they're going to expect everybody might be a secret shopper, and this is what I need to really present myself. So again, I mean, there's a lot of spins that could happen, but I understand that there are the challenges too as a healthcare district.
I do think that, every patient really is a secret shopper, whether they know it or not, because they do receive a survey. I know we're not perfect in terms of making sure every survey gets out to every patient, but I think in large part, we do really pride ourselves on getting good feedback from the patients. I know that this health system scores in rarefied air in terms of patient experience, but, this was kind of more of a targeted effort that, likely will take some additional time to really think through this. But I do pride ourselves on the fact that we do reach out to patients and we do care what they think about the services that we provide. So this is just an add-on.
Yep, exactly.
I have a question, Alex.
Go ahead.
Thank you very much. I'm curious as to what kind of feedback you've received about the doula program.
I had definitely just several friends reach out to me that were really excited about that opportunity. Essentially, there's a cost to the hospital to put them through this training, because the doula training California does have specific regulations around who can be a doula. And because it's a volunteer program, a lot of it was trying to garner whether or not there was enough feedback or excitement in the community for someone to go through this program and then commit to a period of time as a volunteer. Because obviously, as the hospital's going to pay for them to go through the program, we want to make sure that they are held accountable to provide services back through that. So it's definitely, again, one of those things that's still in kind of the planning phase. I know there's at least 4 people that I know that are really interested that did reach out. And so hopefully it's something we can implement in the future. Unfortunately, a lot of times these discussions kind of get stalled for various reasons, but a lot of it is really making sure that we are listening to the community, that we're, being advocates both for the community to the hospital, and then also advocates for the hospital to the community, sharing initiatives that are happening and making sure that people have, we know the healthcare system is really challenging in general, and, and birth obviously is a challenging time for a lot of people, so it's a great opportunity, I think, to engage people in the community into what we're doing. So hopefully it comes to fruition, but I know it's one of those things we're kind of stalled on currently.
Karina, I have a question for you. It seems as though many of the members of the PFAC board have arrived there through various channels, various journeys, and what have you. How did you end up on the PFAC board?
Well, I, like I said, 20-year resident in Truckee. I have 2 kids, both born at Tahoe Forest. I have a 7-year-old and a 10-year-old, so I spent a lot of time in the hospital district, and I also have a master's in healthcare innovation, so I've spent a lot of time studying the healthcare system and the challenges with the healthcare system. I'm a nutritionist, so I work for more of like the holistic side of things, but I'm really passionate about trying to see incremental change, and I think it's really challenging because there's a disconnect with the perception that patients have of healthcare system, and I see a lot of incredible physicians that are burning out because they're it's all the middleman challenges with getting insurance and coverage, and so I really wanted to be a part of the community and helping to make sure that people had access to understanding their care, understanding their insurance. So it's one small way that I can be a bigger part of the community. So.
Sort of thought you had an interesting background.
Yeah.
Thank you.
Facebook group?
It was a Facebook group, yes, that somebody connected me with Alex, and yeah.
Yeah, I'm not on Facebook, but I think one of my colleagues, I had her just put a little blurb out about the PFAC because I was just looking for different channels and different ways to get out to the community that we exist and that we're here and that we're open to people joining. And Karina was one respondent.
Yeah, it was on the moms
Chris
group,
too,
so yeah.
So we had a couple answer through that, so it was great.
Yeah.
Yes.
Thank you for the presentation. You mentioned Press Gaining, which obviously it's important in healthcare system, and I loved what you said about you identified trends and changes, you implemented changes with administration, so that sounds awesome. And so I guess my question to you is there something that stood out? Is there something that you look towards to 2025, whether it be the process in implementing, or is there a certain trend that you see that requires, that you look forward to next year? And it's okay if you don't. I mean, it just sounded great. I was just curious. I'm more curious of your experience as well in that.
I mean, my personal goal, which I would bring to, the meeting when we revisit this, is just doing my own seeker shopper and going around to facilities, urgent care, whatever, and just kind of assessing where we have access to surveys. Because I think when someone goes in and has a visit, and, I'll be honest, I haven't filled out my surveys all the time because sometimes they come in inopportune times and I get busy. But every chance we have to engage a patient, I think, is important. So when they're in a waiting room waiting, let them give feedback then. Let them give feedback whenever they're interacting with the hospital environment. So I do think, if the survey questions include that, did you have a visit? Were you waiting for a visit? And having both, qualitative and quantitative assessments on some of those too. And I think sometimes with the qualitative, it can be like a diatribe of information, which is why the chat GPT, I think, is helpful to kind of, field trends, which one of our other members suggested, which I think could be a good tool. So, yeah, I think feedback is a gift, but I think we have great services, but I also hear some of the negative from the community. And then I ask them if they filled out a survey, and it's like, no, my experience wasn't so bad that I want to throw anybody under the bus, right? It's like, and so then there's this kind of holding back that we also see, I think. And so, some of those people I've sent to Alex and, really encouraging them to speak up, because we have seen the trends where there was a couple examples from different departments where they scored really low, and then there was some feedback specifically that they implemented, and then sure enough, on the next survey, responses, it was much higher. So it does make a big difference, when we have actionable items where then leadership can make changes.
Thank you.
Yeah. I mean, we score really high overall, so what I hope is, that we don't fall into complacency. We want to maintain that high level all the time, and we want to continue moving it up. And we have done that in the last year over year. I think another thing too is just the response rate. I think nationally, people get over surveyed. So, we know that we get surveys for everything. So how do we provide that experience that is so memorable that patients want to fill that survey out rather than just delete it? So I think that is going to be the key. And we've tried to work with marketing to put signs up and verbiage too that doesn't sound canned to help remind patients, like, we really appreciate your feedback. Please take some time to fill out the surveys, because we really do take all of that to heart, and we do analyze it, and we do read all those comments.
Any further comments from our board? Any from our staff or our audience? Janet?
Janet Van Gilde, the Director of Quality and Regulations. I just, especially for our new board member, we started the PFAC in 2015 at the support of our Beta, sorry, my New England's coming out, Beta Healthcare Group Liability. They supported us attending education. Our first meeting was in 2016. Alex recognized, and now it didn't, many of the three new ones, and we have Karina. I wanted her, since this just closed, could you please share our other members just so that we recognize them as well? And that's all I wanted to say. Thank you.
Kevin Ward, Sandy Horn, Violet Nakayama, Alan Kern, Kathy Hansen, Karina, Chris Valerio, Jane Rudolph Bloom, Amber Mello, and Shannon Stroney. That's our full roster.
And a great roster that is.
Yes.
And I hear you're going to be adding to your roster.
Yep.
And we look forward to that as well. So thank you. Okay. Then this was for board discussion, and again, we look forward to hearing from you next time and what further things you've come up with, especially advancing some of those initiatives that you really want to do.
Yeah. Thank you so much.
Thank you so much.
was nice having you, Karina.
Yes, appreciate being here.
All right, Dr. Reichert, I think it's your turn now. Dr. Reichert is going to present the Cancer Center Quality Report.
Oh, okay. And this is the forward. Okay, my name is Sonia Reichert. I'm really honored to be here this evening to present on behalf of the cancer program. I have my other team members here, Dr. Aaron Capel and Dr. Tom Semrad. Our other physician, Dr. Katie Lagaza, was unable to join, and Mackenzie Daines, our nurse practitioner. So this is our annual report. 1 year ago, I sat in the audience as a very new team member, and Dr. Capel graciously presented our report from last year. So I'm really thrilled to be the one sitting in the hot seat tonight. Okay, so just another point, so medical oncologist, and I also hold title as being the chair of the Cancer Committee and the Quality Program Chair. Kelly Bottomley was unable to make it today, but I work very closely with her, and she holds the title of the Quality Improvement Outcomes Credentialing Compliance Coordinator, so she does a tremendous amount of work behind the scenes. So first I want to just go through a few metrics around the cancer program. And this graph you'll see a couple of times here in the early parts of the slides, looking at essentially the growth and the milestones that have happened over the years. And you can see from the inception of really only being a 4-chair cancer program back in 2006 under the leadership of Dr. Heifetz. And then the tremendous growth and the milestones that have happened to make the cancer program what it is today. I just want to call attention to that flat line that you see at the ladder on the right-hand side. And that's really what we're looking at, that stability. So our goal is to keep us stable at this time. We've hit a place of stability, which we're really happy with and provides us the best quality of care. So moving on to the next slide, this shows the physicians over that same graphical time period, just for reference so you can see. And again, stability right on the top there, and that's where I joined. This graph is actually looking really just in the last 7 years at, and it's a tiny bit more curved upwards, but the number of patients and the blue line is representing the medical oncology patients that we see on a year-to-year basis, and the bottom orange line is looking at the radiation oncology visits year to year, and again, very stable lines. This graph looks a little different. So, and this is referencing the number of treatments we give each year. So the last graph showed you stability, but what you see here is the number of radiation treatments per year, and it appears like we're decreasing the amount of radiation treatments. And that is true to an extent. What this is reflecting is that our patterns of how we treat cancer with radiation have changed, and that's happened nationally. We are much more effective with the way we deliver our treatments. Previously, we might have given a treatment for a bone metastasis at 20 treatments, and now we can do that in 1. Breast radiation previously used to be 33 treatments. We now do that in 21 treatments, and so on and so forth. So there's a lot of national trends that you can see. The number of patients we treat might be the same or are the same, but the radiation fractions are decreasing. I'm just going to take a pause for water. Hold on a second. So I want to take a step back and actually move more to the quality piece of my presentation. And you probably hear as board members, references to accreditations, reaccreditations, and memberships, and it really is important to recognize why we would even do an accreditation. So in our cancer program, we're not required to be accredited with any organization to practice and deliver treatment. We do this because it is voluntary, but it holds us to a certain standard, it drives excellence, and it gives us continuous improvement in our program. So we embrace the opportunities to have these accreditations and memberships. And this just outlines the specific reasons. We actually hold multiple accreditations, and we do this because each accreditation body really focuses a slightly different on the aspects of care. We think about the way treatment is delivered, how safety is delivered, our research and our community impact. It gives us an opportunity to have very rigorous standards to nationally recognized committees. We drive our performance based on data and outcomes, and we do this with annual goals and real-time goals. So we're constantly reviewing these goals and looking at them and thinking about them real-time as well as in set points annually as well. So same graph, here you can see the accreditations over the years. We have 3 primary accreditations in the box up on the right-hand side. That's not our only 3 accreditations, but every given year there is either an accreditation or a reaccreditation that we're preparing for or presenting to. In 2024, we had our COPE reaccreditation, and next year we have 2 accreditations, which will be the American College of Surgeons, or COC, Commission on Cancer, and the ASTRO. Again, it's a slightly different format, but a tabulated version of those accreditations and affiliations. So 5 accreditations and 1 affiliation, which is the bottom with UC Davis, the Research Cancer Care Network, and the status, which is just for reference. And then this is, again, just referencing those same accreditations and how many practices participate in these accreditations. So we are one of those practices participating. And so the top one you can see really is a large number of facilities that might that participate with Commission on Cancer, but some of these other ones are not as commonly used, and we've taken that as challenges and opportunities to participate even when other practices may not be. Some cancer program highlights with respect to our accreditations. Our last Commission on Cancer accreditation was actually in 2022. We were fortunate to have performed so well that we had 0 deficiencies or abnormalities within that reaccreditation cycle, which put us at 4% of all programs who could be able to have met that goal. It is very common with these accreditation cycles that you would have a list of things to take from that and actually improve upon. And so when we go through these cycles, we perform incredibly well. This year, our American Society of Clinical Oncology, the COPE certification, we are one of the highest scoring performing programs within the country, and we had such a wonderful site survey that and the information from that is just coming in, but we did not get any deficiencies in that certification cycle either. UC Davis, our clinical trial accrual, our enrollment numbers are actually on par with NCI designated cancer centers because of the number of patients that we engage with research, and patient satisfaction survey results are consistently greater than 95%. So, Commission on Cancer, and I might reference this as COC if I forget, but Commission on Cancer gives us, this is just a graphical representation of the breadth of what we're being evaluated on. So it's not just on how we treat cancer. It starts from prevention, goes through cancer screening, certainly goes through diagnosis, treatment, but also recovery, survivorship, how we engage with our psychosocial aspects of cancer care and palliative care, distress, and even how we navigate patients. So all of those things are metrics which we are reporting on. Just for reference here, those same domains, but the specific subheadings that we are reporting on through our credentials. And the quality care measures. So we use Cancer Registry, which is it is a nationally standardized way of reporting our data. It gets reported to the Commission on Cancer. It gets reported through CMS and the National Quality Forum. And what's really important about the registry data is that performance is actually at a hospital level. It's not just outpatient level. And we have measures that hold us accountable. So it's publicly searchable. It feeds into payment incentives. It's how consumers, i.e. patients, can consider to select us based on our performance. And also it's the way that health plans and purchasers will actually be engaging with us in the future. I think we're sort of seeing some of that now. And it gives us an opportunity to do quality improvement measures because that data is important for internal monitoring. All of this data reports up to the Cancer Committee, and as we said, we report on those outcomes. A little flavor for the quality care measures, multiple different disease types. You can see this listed in this table here. And I just want to give you a little preview as to what we have reported for 2024. So this is the breast data. You can see on the left-hand side the expected performance, which an institution might be sort of aiming for. At Tahoe Forest, you can see that we like to exceed the expectations. And it gives us an opportunity to compare us to the state of California as well as the national program. So you can see we generally trend at 100, if not just under 100% for our quality measures. I mentioned that 2024 was a quality oncology program initiative, or a COPE reaccreditation cycle. It takes many, many months to prepare for these reaccreditations. And so we did submit our data in June of this year for this reaccreditation. It may not sound impressive, but to have an 89% compliance of our data submission is actually is phenomenal. It takes a lot to submit, scrub the data, make sure that you're removing things that are not supposed to be there. So this was an incredible amount of work, and Kelly Bottomley really leads the charge with this. And we're grateful for all of her involvement in doing this and understanding how best to do this. We had our site visit on October 1st, and there was really a focus on 3 different measures that we focused on this year, and that was oral chemotherapy, which is the treatments we give for cancer that are in an oral form, how we...
Bed 6, ER.
Wait.
Bed 6, ER now.
2 times. Okay. How patients adhere to their oral chemotherapy and how we assess them through intervals. And this last focus was also on pregnancy testing prior to chemotherapy. That might seem like a very routine thing to do. There is very few programs across the country that have figured out how to actually address pregnancy and risk of pregnancy during treatment. And, Dr. Semrad took the lead on this, and we really nailed it. They were very impressed with this. So this is already something that has become standard of care and practice within the cancer program. Okay, so moving on to other data that we reported on this year. So we did a real focus on breast cancer, actually, and so looking at genetic counseling and risk assessment for patients who get a breast cancer diagnosis, and how we monitor concordance with evidence-based guidelines. And so in order to do this data preparation, we actually had to look back at 2023. So in 2023, there were 93 breast cancer patients diagnosed, and we recognized that 73% of those patients were eligible for genetic testing, and they were referred for genetic testing. 2 patients declined testing, the rest of them underwent testing. There were 27% of the patients that did not get genetic testing or were not referred for genetic testing, and that's because they were not deemed necessary. Not everybody requires it. So we were very happy to have seen that we actually addressed that and thought about that consistently across those 93 patients. Of the patients who were tested, there were 9 patients who were found to have a pathogenic mutation. What that means is that they had an explainable reason for their breast cancer diagnosis, and also puts them at risk for additional cancers. This has a really important therapeutic implications, how we treat and manage these patients with a specific mutation. And also, this has a tremendous impact on first-degree family members. So we're looking at essentially 9 families affected who have their own potential risks for future cancer. So this is pretty impactful. It may not seem like a big number, but it really is a big deal. So our conclusion was that our genetic testing was appropriate for tumor biology in all cases. And looking forward to the future, this is something we're actually really excited about. The Commission on Cancer has actually personally selected the Tahoe Forest Cancer Program to participate in a national quality study. And they're really looking at barriers to genetic testing, standards, outcomes. This is something that's a national focus because it commonly gets missed. So we're looking forward to seeing how we can contribute and what that looks like in the 2025 quality program. Then the next step was to look at the breast cancer patients and get a better idea about how they were diagnosed and how they were treated. So I'll just move on to this slide. Of those 93 patients, 82% of them were diagnosed in early stage, so stages 0, 1, and 2. This is really important to just pay attention to. It essentially does tell us that we have a really good screening program. We're diagnosing cancer earlier, and we're really trying to avoid late stage cancer diagnosis. And then secondly, how they were, how did they come to us? 45% of those patients were diagnosed and treated within Tahoe Forest, and another 40% were diagnosed elsewhere and referred to us. There's a little 8% over there on the right-hand side, and those are patients that are kind of classified in between, so they might have come in and out of our program, so they kind of get put separately. And finally, what kind of initial treatment did they receive? The vast majority of patients received a lumpectomy, which is just a small partial removal of the tumor itself within the breast. Another 36% had mastectomy, and 11% did not have any surgery. And they were all considered appropriate because either based on their stage or the specific biopsy or the appropriate treatment, those 9 patients actually underwent chemotherapy or some other form of treatment. So we will be actually looking next year at the lumpectomy rate, just to kind of understand the difference between the lumpectomy and mastectomy, what choices influenced that. So that's a goal for 2025. Moving on to radiation oncology, so led by Dr. Lagaza, Bruno Carlini, and Kelly, we are in our second year of a national study, so part 2. Part 1 was 2023, looking at factors that contributed to patients canceling or no-showing their radiation treatment. This is relevant because missing treatments in that's designed to be sequential can affect the outcome. It can affect the goal of treatment. So we identified that there were barriers to treatment, and there were patients who were skipping and missing effective treatments. The first barrier was weather, difficult for us to control here. But the second was transportation, and this really was an opportunity to see how we can reduce that barrier. So identifying that and then implementing a practice change. So the first one was the American Cancer Society. We have a $20,000 grant for gas cards. We also have a South Lake Tahoe Cancer League Drivers. That's a voluntary program to get people from South Lake Tahoe up to their treatments. And a separate American Cancer Society grant of $10,000 to help patients with lodging at the Hampton Inn so they have easy access to their radiation treatments. So in implementing that, we found in 2024, we were able to 50% reduce the number of missed radiation treatments. Again, we're talking about small numbers, but very meaningful. So we had 5 patients who missed 3 or more treatments. That was a significant reduction from 2023, which was 10 at the time. So of the patients that we accessed and provided these interventions, 94 patients were screened for gas or lodging, and 47% of patients received transportation in the form of gas cards, and 8 patients received lodging. I'm going to move on to the STAR bundle. This is a buzzword. I'm sure you've heard about STAR bundle from CMS. We just own one little small piece of STAR bundle, which is the reducing emergency visits for patients who are undergoing chemotherapy. So within this, the really work that's been focused for 2024, the idea was that our implementation would be for our new chemotherapy patients, we'd provide extra education, work on prevention, managing our symptoms, the symptoms of patients from an outpatient standpoint, much more involvement and engagement. We have nurses who call patients post-therapy to check in with them. And our compliance with our measures was 100% throughout the year. And as you can see, that intervention has reduced. You can see that trend line is reduced the number of ED visits and admissions for patients undergoing chemotherapy. We'll never really, although it looks like it's zero, we'll never really expect to get a zero on cancer patients not going to the emergency room. But the goal is to reduce visits where we could be taking care of them from an outpatient standpoint. Okay, so moving on to the clinical trial program. Dr. Semride, who is sitting here, leads the clinical trial as the program director. We have Ray Heaps, a clinical trial research coordinator. And as I mentioned before, we are part of the UC Davis Cancer Comprehensive Cancer Network. We are one of 4 centers outside of the UC Davis campus that have this affiliation. And we've had this affiliation for over 10 years. And it's really how we access our clinical trials that we offer to patients. This slide is November 2024 and is already outdated because the program is very busy. So there are many studies that are being reviewed throughout the year, 13 studies, and again, that's a little bit outdated at this point. We have 4 studies that have been activated this year, another 4 pending activation, and we deemed 9 that were not appropriate for Tahoe Forest that were rejected. So our current portfolio, again, outdated on the side up here, but we have 24 active studies. We have 24 open to accrual and 1 study on hold. And this graph shows you basically that on the left-hand side, it's the active patients that are actually going through some form of interventional therapy. And on the right-hand side, you can see the bar graphs that are the patients are in follow-up. So we have a very active program, especially given the size of our program. So 44 research patients is really tremendous effort. It was also a busy audit year for the research program as well. We had 2 audits, NRG and SWOG. Both of those are by the National Cancer Institute, so NCI. These are the subcommittee groups. And so we had multiple charts that were selected for audit. It was kind of a bit of a surprise. But that being said, again, Tahoe Forest Cancer Center met the challenge. The auditors were thoroughly impressed with how well organized and documented the charts were. We had a very short window to prepare for those sort of surprise visits, but we were able to pass through with no deficiencies. So again, a tremendous effort from the research program. Finally, actually, this may not be final, but patient satisfaction. I just heard about this last week, and I was just thrilled about this. So in December, we were announced as being the recipients of the Press-Ganey Guardian of Excellence Winners Circle. This is exemplary performance, which is recognizing a ranking of 95th percentile above for patient experience across the entire calendar year for the cancer program. There was something else, see? This is a new program that we instituted in 2024, looking at financial barriers to care. So as you can appreciate, anybody who has a cancer diagnosis can be met with a lot of financial challenges, and we really thought carefully about how that was impacting our patients and what we could do to intervene. So it's been an evolving sort of idea, and there's been other interventions over the years, but we're really solidifying this as a financial navigation program. We expanded our support to an extra 1.0 FTE so that we could address the growing needs of the patients. I'm not going to go through all this, just so you know that there's goals, there's projects, there's things we work on to make sure that these barriers are evaluated on every single patient. This is an impressive slide, so in your packet for reference, but in 2024, we collected over $213,000 dollars for oncology and non-oncology patients, non-oncology drugs for our patients. So this is not money we laid out, it's from other agencies that provided financial support to our patients. We had 130 new patient encounters that were navigated through patients. We enrolled 52 patients into these external programs in order to secure these funds. So this is really, I've been at multiple different cancer programs. I've never seen a robust financial program that has accomplished this kind of feat. So I really want to commend the team and this cancer program for setting this up. And this is a great graph. It shows the supplemental resources, so pulling from all resources that we can help support our patients. And you can see different lodging grants there, different financial supports, the oncology services that we provide, and even Talk Connect and Lyft rides that we do provide for patients who are in need. So any great program, there is change. So change is inevitable. I'm the first bullet point on there, so I'm the newest physician member, and like I said, I've been here for a year, and I'm just honored and thrilled to be a part of this program. We got a new clinical manager in December last year, Katya Lektorich. We have a new oncology pharmacist that started also in December last year. Ray Heaps, who was here already, she moved into the new clinical trial coordinator position and has just done a phenomenal job. Karen Aaron, our nurse navigator, who actually set up our nurse navigation program, officially retired, but she stayed on to help us develop the oral chemotherapy program. And but one thing I do want to highlight is that what does not change is our culture of commitment to the highest quality care to our patients and our community. We think a lot about this, and as a team we discuss what sets us apart, what makes us special, and we call this our secret sauce. I think there's the top three is, how we deliver this. So we are very personalized. We're small. We really focus a lot on highly individualized attention to every single patient. And we do this because we discuss every single patient every single day. And we're really thinking about, people throw the word, patient-centered care. I have witnessed this on a daily basis, how everyone will contribute and think about, okay, the patient's arriving at this time. Can we move this around? How do we make the experience revolve around the patient and not about what's convenient for us? We're very comprehensive. Our nurse navigators, their guide is to establish with patients that first point and bring them through their first course of treatment, but they do so much more than that. And they follow patients way beyond their first initial treatment. And then there's the culture. And the culture is something that it's hard to replicate, it's hard to teach, it's hard to train, it's not a module, it's something that's very organic within all of us. We have an unwavering commitment, and this is not just in physicians, I'm talking about every single individual who works in the cancer program feels this way. We have an unwavering commitment to our community and to delivering the best care in the nation or in the world. We have a passion. We love what we do. We come to work with enthusiasm. We love education, and we believe that our roles are about lifelong learning. And finally, we're a culture of excellence. Process improvement isn't just a policy. It's an organic, self-driven way of life. And with that, I end. I'll just say, together we're shaping the future of cancer care for our community. And thank you so much for having me.
Thank you so much, Dr. Reichert, for that presentation. It's always stunning to me to see how much is being done for our patients, and especially those with cancer, and what lies ahead for us, because we don't know who's going to have cancer in the future. We look around and we see what the risks are and think, well, we've got this center here that we can use. So thank you again. Thank all of the individuals in the Cancer Center for the work that they do for us and our patients.
Question, if I could. Years ago, Melissa Game advised us that 50% of the people being treated for cancer came from outside of the district, a normal service district. Does that hold true today?
40%.
It still does. I would say that those are patients. I mean, we're somewhat of a, in a rural community, a wheel and spoke model, right? So we're a center that many surrounding communities would not have access to care. So when we're thinking about our regional Tahoe forest, how you think about the region for surgery or for OB/GYN is very different for how we would think about the region for cancer. So we have to have a much broader scope because cancer, if you're in a mountain community, it is impractical to drive 4 hours to get cancer care in another regional center. So we become the regional center for a lot of communities, even if they might be not in our traditional catchment area in other departments. So I think it's still within the, our mental thinking about how we would care for that community.
Yeah, but it also seems that for those who are living in the Bay Area or larger districts, that they would have their cancer surgeries at UCSF or Stanford, and they have a second home here. The chemo and radiation would be much easier for them to get in this area. Is that still a possibility?
No, I understand what you're asking now. So when we talk about kind of 50% are local and 50% are outside, I'm talking about residents who live here, and I think Dr. Kane would have been referencing that too. So we consider South Lake Tahoe as not really our region. For cancer it is, but it's not for, for surgery services or for, GI services. They have their own Barton hospital, but for cancer that becomes our region. So the 50% that Dr. Kane would have quoted is not what in practice we see. I'm not seeing patients coming to our clinic who have easy access in the Bay Area who decide just because they have a vacation home to get treatment up here. That's not as common. Really the 95% of who we see, 98% of who we see are residents who live here. They may occasionally move out of the area and get care elsewhere for a period of time while they're away, but while they're residents here, either permanently or for many months at a time, they are getting their care with us.
Yeah.
I hope that answered. I'm sorry, but
It did. It's just, last year I went down to the Bay Area. A good friend, her husband was having chemotherapy regularly, and I took over for her, let her vacation while I ran him every day to, I think it was Kaiser Hospital in Walnut Creek, and there was 25 people getting chemotherapy. On any given day, you have very few people in your facility. Certainly, if I was him, I would have wanted to come up here to my second home if I could avail myself of those services here. And I just wondered if that's happening.
yeah, not as much as it might be as, I don't know if you want to chime in. I don't think it's...
I think it happens. It happens. Frequently.
Yeah. The larger numbers, though, that Dr. Kame has mentioned, sometimes we look at it like primary service area, right? So where our patients come from primarily. Then we have another bucket of patients called the secondary service area. And so that will incorporate a lot of the rural communities that Dr. Record just mentioned, right? So I think when we're talking about numbers that large, that's what that looks like. But surely there are patients that in-migrate from other communities outside of even our primary and secondary. It's just when you think about 50%, really what we're talking about is primary and secondary service areas.
I have to tell you that I have a friend that's going to be coming to the cancer center, and she was told by her primary that, if someone doesn't call you in 4 days, call me and I'll get you in. And anyways, on the second day, somebody from the cancer center called and just relieved her of so much stress that she was having, gave her names and who will contact her, and just led her through the journey that she would start with. And I have to tell you that she's a changed woman now, knowing names of people. And so again, she's not a secret shopper. She's going to be really there with you. Any other comments about the presentation and the quality or the cancer center?
Well, a comment and a question. The comment is, I can't hear the words cancer center and in that same sentence, words exceptional, life-changing. I mean, it's just the reputation for this cancer center, not only locally but beyond, is incredible. I've personally had colleagues, that have moved here just to be treated at the cancer center. So, I mean, the work you do, evidenced by the data, is just nothing short of remarkable. I'm gonna jump ahead. I know we do committee reports later, but this one is relevant. We just received the largest gift ever at our foundation, $1 million gift to the cancer center from a cancer patient. I mean, the numbers speak, right? So thank you for everything that you do. The question I had, you mentioned in the benefits of the COC, cancer prevention activities was one of the on the left side of that chart.
Mm-hmm.
Can you share some examples, or what's the scope of prevention activities that we participate in?
Well, so we did a little bit of a focus on with breast cancer this year. So breast cancer screening is first and foremost with that with that disease type. So there's a lot that we're thinking to do. We're really trying to focus on the communities that have very little access. It's somewhat challenging if patients don't have insurance. You can get a screening done and we can get those kinds of activities done, but the follow through can be a little bit more challenging. So we're working on that for a 2025 goal. And so outreach on getting our mammogram numbers is actually something that our cancer program is looking at, and it actually has one of the pillars within the hospital network as well. There's another really important goal of colorectal screening. That's an important goal that the hospital has. So we're partnering with the hospital pillars again. So sort of bolstering up our GI department and making sure that access to colorectal screening, both colonoscopies as well as the stool study testing, is going to be really ramped up. So there's a lot of collaboration between hospital and the things we're doing in the cancer center, as well as the goals of the COC program. So it's really a lot of like drilling into specific diseases, and then what are we doing, how are we getting our numbers, but it's all driven by metrics, right? If you don't know what your screening screening rates are, you can't intervene on it because you don't know if your intervention's better. So that's the point of COC, is that it drives you to look at metrics. It forces you to report on them and then intervene and then report on your intervention. And these all come with, when we do our reaccreditations, we have to present that to the site surveyors, and they review what we've done. So it keeps us honest.
Thank you. I've got one more question if I could. That chart of cancer center radiation program, with that precipitous drop.
Yeah.
That line. Are the results that you're getting, even with reduced treatment, the kind of results that you...
Absolutely. Our radiation machines are so much more effective, and the way we deliver our radiation is so much more effective. So we don't need to give as many treatments to get the same outcomes. And that's, again, I'm referencing this as a national practice change. So this is mirroring what's happening across the country.
This wasn't something you dreamed up, it was, okay.
Yeah.
Just curious.
Yeah, and that takes it's essentially, I mean, every single month we get new studies reporting on saying that we can scale back on our treatments and make them just as effective with less toxicity, and that's very much been true with radiation.
Okay.
Okay, go ahead.
Thank you. Wow, that was amazing. Thank you for presenting. And I think just pride. I think so proud of such a great system, a great presentation, and great culture. So thank you, Dr. Louie. That's something to be very proud of, to just build something. I think I wanted to kind of expand just Dale's point, because when I was campaigning, people talked about carbon footprint. We had climate presentations here about people coming from areas. So I think it's just more of a comment. I think that story of being primary, secondary versus the Bay Area is a story worth telling. That this is providing the community that needs it. The community can't reach it. I mean, that graph of all the finances you had for people from South Lake to staying over, those are great stories. So just giving feedback from talking to people about this, I want to just weigh the importance of that. That's really important. And second of all, I think, I don't have a question. It's still in my head. Maybe I'll get to you later about culture. Is there a story? Is there a moment when the culture was developed like this? Is there a moment that happened? I mean, because that's exceptional of what I've just heard. And I think culture will always, you have strategy, you have everything, but when you have that culture, that's what makes everything so special. So if you don't have a story, that's fine. But I was just curious.
A bit of a story. I mean, we have to give credit to Dr. Heifetz.
Yeah.
You never knew him, but Larry Heifetz was the founder of the program. Oh, yeah, sure. Okay, I'll start from the beginning. Is this thing on? So Dr. Larry Heifetz, we have to give credit to him. He was the founder of the program. And his idea was we have to have an amazing patient experience. That was always his message. But also, we need to have a good doctor experience. And therefore, that leads to a good staff experience. And so that was part of it, is really the patient comes first, then the doctors and the staff. If everybody has a good experience, that's going to lead to good outcomes and good quality care. And I want to thank the administration here because they've allowed us to have more time with patients. So, the time we have with patients in this center is very different than, let's say, other institutions. We have 30-minute follow-ups and 1-hour consultations. And so if you have, 30 patients and you're running around with your head cut off, it's very difficult to have good quality of care. So thank you to the administration for allowing us to have that model. But it was really Dr. Heifetz who brought the model and the culture into the program. And then we as a team disseminated it and have kept it going. Thank you.
Thank you.
Mary, anything?
No, I don't have any questions either, Alice, but I do have so much praise for what you do and how you do it, and so much appreciation as well. So thank you. Thank you.
Thank you so much.
Any comments from our audience?
Well, I do have a quick comment. So, of course, we were fortunate enough to watch a presentation on quality, but I just want to quickly make a comment on the quality of the presentation. Wonderful job. Clearly, you were passionate about this work, and I know you joined the team recently, and we're just so fortunate to have you here with our team and here in this community. So thank you so much, Dr. Reichert. Thank you to the rest of our oncologists and the entire team at the Tahoe Forest Cancer Center. We are so prideful of you, and we're so thankful for you.
Okay.
Thank you so much.
Thank you again, and we look forward to more reports in the future that are just as stellar. So our next item on the agenda is, it's an action item, and it's the board culture and norms. This was a document that the governance committee has been working on for several months now. It came out of our retreat last April with some thoughts about eliminating what we had, which was the order and decorum. We felt that that belonged to meetings and that we have the Brown Act that leads us to it. But what we were looking at are our behaviors and the culture of the board. And those ideas came from the board members, drafted into a document. And we've gone through 2 iterations of it at our September meeting. There were items that you would like to see revised, more of a wordsmithing, and then some that you did not feel were part of what the board saw as their culture. So we have put those revisions on our on our board effect, and at this time, I'd like to have a discussion of what those changes have been like and what the board would like to do at this point. We felt that we addressed everything. We divided it up according to areas of interaction. There was a part that had to do with just our board meetings that was very simple. But how do we interact with the public? How do we interact with each other? How do we interact with the president and CEO? And these are guidelines for all board members so that we know what to expect and that there's an effectiveness to our actions. For our new members, this is a guideline for them to begin to take on their responsibilities as a director. Any comments?
Alice, I have a comment.
Okay.
Thank you for bearing with me through this whole process for the board culture and norms. I want to tell you all that I think I was mistaken. I learned at the ACHD conference that we went to that most boards have this sort of policy in their binder and find great value in it. And so I stand corrected. And I would also like to thank you for putting so much time and effort into that one change that was so sticky. And if there aren't any other questions, I would like to move that we accept the culture and norms.
Oh, are there any other questions?
Yeah, I just have one thought, and it's under number 29, starts with number 29, interactions with the public. Do we want to say anything that in our conversation with the public, we can represent ourselves, but we don't represent the board? Is that something that is important to have in there?
I think there is something, I thought we did have something about speaking for yourself. But is it something that you do want to add if it's not there already?
That was the only suggestion I had. The rest of it seems fine.
What's your opinion, board members?
As I understand it, said something in there that you're not speaking for the board, and that the board chair can do that, or it can be referred to the CEO.
I think that's referring to more either general comments or if there's something in the media and someone, it should be the board chair that's actually representing the board. I think what you're speaking to, though, is if you're speaking to the public in the grocery store,
Yeah.
that you're representing your views and not those of the board.
Correct.
Okay.
No, it's not written in there. Is that something that you would want to add to it? Or is that a given? There is nothing else under any of the other ones that speak to a board member only speaking for themselves, though it's a known policy or it's a known practice.
Can we approve it if with that change? I actually do like it because it's under interactions with the public, something along the lines of, when interacting with public one-on-one, let them know you're representing your views, not those of the board. Or,
Yeah.
I think it's something we all do, but
Yeah.
I'd be in support of adding a sentence under
Yeah,
somewhere between
interaction with
29 and
the public
32.
is where it would go.
Yeah.
So. I would be okay with approving it, subject to adding that item.
So Alice, I'll amend my motion.
Okay. Martina, we could add something to it and then approve it? Okay. So we'll add it to interactions with public, and it will be a member of the board when speaking represents only himself or herself.
Makes it clear that they only represent.
Yeah.
Lets it be known that they only represent
However you
his or
want.
herself.
Martina, did you get anything down?
Here comes our wordsmither.
Yeah.
Right here.
Yeah.
I think perhaps something like, be mindful that you represent your own views and not the position of the board, not the position of the full board. You may represent actions that the board has taken, certainly, but when discussing matters, be mindful that you are representing your own views and perspectives, not that of the collective board.
Can you make that into a simple sentence?
I think I did at the very end. Martin?
Be mindful that you represent your own views, not that of the collective board.
Thank you.
Thank you, Martina,
Thank you. Perfect.
very much.
Dale, I thought you would, though, were saying that you need to make it clear to the person that you are only representing your own view.
Yes,
I mean, it's one thing for you to be mindful of it, but you got to tell the person you're talking to that you only represent yourself.
right. True, yeah.
Can you,
So communicate that you are representing your own views, not that of the collective board.
Yes, thank you.
okay.
Yeah.
So we'll add that to interaction with the public, and then it'll all be renumbered? Okay, Mary, do you want to amend your,
Yes, I'll amend my original motion to include those words.
Chair Wong, could we ask for public comment as well?
oh, I'm sorry.
Thank you.
We had one. Any public comment on the addition? You good?
Okay,
All right, thank you.
I'll second it.
So it's moved and seconded to accept the board culture and norms with the addition of interacting with the public as been presented. Yeah.
Martina got it.
Okay? All in favor?
Hey,
All opposed? So the culture and norms for the board have been approved with the addition. So thank you very much for that. There was nothing pulled for our consent calendar. So 17 is board office elections, and every year we do an election of our 5, I think it is, officers. And the first office that we would like to vote on or nominate someone for is the chair position. So are there any nominations for the chair of the board of directors?
I would nominate Michael McGarry.
I would second that.
Michael, would you accept a nomination?
with gratitude for all the years you've been chair. I think all of my years on the board, you've been chair. I would accept that nomination.
All right.
So I have a motion, I have a nomination. Can I have a second to the nomination?
Go ahead, Rob.
I second the nomination.
All in favor? Do we need to take a roll on that one?
Well, I move that the nominations be closed.
Oh, I'm sorry, that's true.
Yeah.
So do we have to do a roll, Martina? No? Okay.
Do we want to second his motion to close nominations?
Yes.
And then,
Oh, then you have to,
depends on if you want to be very, very thorough. You'd take a second, and then you'd vote to approve that we've closed nominations, and then you'd actually vote on.
okay, thank you. We don't do this very often. We don't go this far. Okay, so,
So I'll second the closure of the nominations.
okay, all in favor?
All right.
Okay, then the next one is,
Vice Chair. Well, actually, he gets to do it now.
okay,
Oh, uh-oh.
I'm so confused in how we do it now.
Got to vote on this nomination.
yeah.
That just closed the nomination period, I think.
Yeah.
That's
So the
And now-
Nomination is
now-
closed. Now we must vote
Now
on
we
it.
vote.
So now we vote.
Yeah. So all in favor of Michael McGarry being the chair, say aye.
Aye.
All right.
All opposed. Michael McGarry is our chair for 2024. So now that Michael is the chair, incoming chair, he will then set up his officers.
And I need clarity on the steps we take here.
Okay, so it goes,
Well, we need a nomination.
right,
For the vice chair?
for the vice
We need a
chair.
nomination. Then we need to close nominations.
See if they accept the nomination, yeah.
Well, nomination, accept, close, and then vote. I got it. Yes, every chair needs a fantastic vice chair. Do we have any nominations for vice chair?
I have a nomination, Michael. You know, I told this person that we haze freshmen. But we don't really haze them, we just ask them to be vice chair.
I am grateful and honored, and I accept.
So now can I make a motion to close the nominations?
Are there any other nominations?
Does someone second the nomination?
Do we have a second or other nominations?
That's what you did last time.
We have a second, and then a motion to close the nominations.
I'll second that.
Well, I didn't make the motion, I'm asking for a motion.
I'll move to close nomination.
We're going to get this by the last
Yeah.
office. Yeah.
We'll have this down by next year.
And we have a second, so then, all
All
in favor of closing nominations?
Aye.
Anyone opposed?
Director McGarry, who was your second on that?
Young man to my right. And then we go to vote? Okay, all in favor of Director Darzynkevich?
Aye.
Any opposed?
You are
Good
the
luck,
chair.
welcome. Yeah. Welcome to your 11th day. Yes. Next, we have secretary. Do we have any nominations for secretary?
Alice, I've enjoyed being secretary so much, I would love for you to have that opportunity.
Well, thank you. I'll read your notes thoroughly, your minutes.
Okay.
A second.
Do we have a second?
I'll second.
We have a second. Alice, do you accept?
Oh, I accept, yes.
All right, can we get a motion to close nominations, or are there any other
No,
nominations?
I'll make a motion to close the nominations.
I'll second that.
And a second. All in favor?
Aye.
All opposed? None.
Close now,
And now we'll vote. All in favor of
Aye.
Director
Aye.
Warren? Aye. All opposed?
the secretary.
Thank you. And finally, our treasurer.
I'd like to nominate Mary Brown.
I love money.
I love my money.
Second, we need a second.
I second.
You love money too.
Any other?
Any other nominations?
If not,
I move the nominations be closed.
I second it.
All in favor?
Aye.
All opposed? And finally, a vote for Director Brown as treasurer. All in favor?
Aye.
All opposed? Congratulations to all, and thank you.
And Alice, thank you. Oh, my goodness gracious.
It's been my honor to be with all of you and the support you've given to the chair through the years. Started with COVID and it just kept going.
Yeah.
Well, thank you.
And just make sure you stay close to me.
I'll tell Steph,
Just keep whispering when I go off course. Next item on the agenda, board committee reports. I believe we had a governance committee on November 20th.
Yes, governance met on November 20th. We did the board culture review and revisions as the board has asked us to. And today you passed that, thank goodness. And then we also went through the board self-assessment. We eliminated an item that none of the board actually put in. It was put in by someone else, so we eliminated that. We put back, I think, the option of neutral in our scale, so that's back into it. And then everybody on the board should have completed it by December the 6th. And then the governance will look at the analysis of it and come up with a plan of action if needed. And the last thing we did was the board retreat dashboard. And again, we took it from best practices and developed a dashboard with all of our items, our work plan on it and where we are. And if you go to Board Effects, it is on the home page. You click on it and you'll see the dashboard. Everything that's green means it's been done. There's some things that we have to update that we finished in November that we have not updated yet. And then we have things that are coming up in the month of February, especially looking at some of our community engagement goals. So again, there's things that we'll continue to work on. And the thing that I liked that we did was we added a column that will tell you where to go to find the evidence that it was completed, whether it's in the minutes of a committee or if it was in a revision of a policy, it'll be dated. And the last thing would be, if it was in the general meeting that we had, you'll see the date of the meeting and you can go to the minutes and find it. Again, it's trying to be transparent where all of this happened.
Thank you.
And that, I think, is the substance, really, of what we did during our meeting.
All right, thank you. The Board Quality Committee also met. We had a few agenda items, but this time of year, gratitude seems to be a theme. And so since you're still here, I wanted to thank you personally for everything you do around quality. Not only the meetings we have, but just everything you do day to day. So thank you. We covered a couple of things. One, under closed session, we looked at fall risks. Again, in closed session, I can't share many of the details, but I do want to echo, I think I've said this every time I've given a committee report, it's so valuable. This is something new we implemented in the last year, an opportunity for us to speak very openly about maybe a specific patient incident or some sensitive topics about the health system, and for the board to have that intimate discussion, not only about the challenges, but also the resolution of those, critically important. So this time we covered fall risk. We were scheduled for an update on the Vizient project and management systems work, but in the district board meeting the night before, we had a very comprehensive review, so we didn't cover that or didn't need to cover that. We did have a brief discussion about the PFAC and maybe some of the updates we can make there. There was, Director Barnett was part of the quality committee. He said, hey, I'd love to do that. So I don't know if he's moved forward on that, but I think he's very excited about joining the PFAC. And then finally, we had a great discussion on, we have an educational topic every meeting, and we had a really fantastic discussion on racial and ethnic bias, and that's something that I think really creeps in to the work we do, to the way we run our lives, whether we know it or not. We always bring biases into the decisions we make or the way we might treat people, and I think the first step is just being intentional about that, being aware of that, and we had a great discussion about ways we're doing that, throughout the organization, and not being complacent and just saying, well, not here, we're great, and there's no bias here, we treat everyone the same. But the reality is, I think when you're intentional and you start digging, you kind of find out, oh, maybe I was a little biased on that. Maybe when that person came through the door, I did think differently of them than I might otherwise. So great conversation on that. And I think that's it on that report. Foundations?
The Incline Village Hospital Foundation did not have a meeting, but we had a party.
Just as good.
No, even better. At the Julie Teal, who is the owner of Rayleigh's, put it on again for the third year, I think. And it's a fabulous affair. Both foundations were in attendance, and a lot of physicians and admin. So it seems to grow a little bit each year, doesn't it?
Yeah, people are finding out it's a great time.
Yeah. Food is free. Yeah, food and drink and, yeah. So anyway.
Well, and the facility at Rayleigh's is fantastic, and it's so kind of them to host every year, for sure.
That's it.
That's it? What happens at Rayleigh's stays at Rayleigh's? No details on the party? Okay. The Truckee Foundation met as well. I already shared earlier with the cancer team here. Somewhat unexpected. It was the, can't read my own writing here. Weekly, I think, the Weekly family. They came in almost thinking that those sorts of donations were common. They're like, oh, we'd like to give a gift, a meaningful gift. That can mean anything. Right, and then when they sat down, the team at the foundation said, well, what do you mean by meaningful? They're like, well, $1 million.
Yeah.
And again, credit to the cancer, credit to the Cancer Center for all they do. But there was also a donation or a gift that happened a while back. It was a property. that was gifted to the foundation. That closed within the last month. It was closed at a $1.2 million value. Went to a local family we all know the housing challenges we have, so it was really pleased, not only a benefit to the health system, but the benefit to the local family that now has a place to call home. There was a little bit of a surprise in that. There was an unknown retirement fund that was actually associated with that property as well. I don't have details on what that was, but a little icing on the cake. But I think what it all leads to, we're just seeing the level of donations going up year over year, and it's just credit again to the reputation of the health system and the work that's done here every day. So a great thanks to not only, of course, everyone in the room, but everyone that might be
Question about that
watching.
$8 million gift. The Incline Village Foundation not only collects the money, but they also participate heavily in how it's to be spent. In fact, it really starts the other way around, and it starts with that. So they go out to the public and say, hey, listen, would you like to purchase our new machine here or there? Or is that going to be true of the donation to this foundation of that $1 million? Are you guys going to participate in how it's spent?
So that was directed to the Cancer Center. So it'll start there, but then to the discretion of the team there and how that's spent. The family donating didn't put any stipulation on how it's spent. And I don't believe the foundation will necessarily be too involved in that. It was, it'll be up to the Cancer Center.
Okay.
Yeah,
If
so
anyone has.
that particular donation was donor advised essentially to the Cancer Center, so it's restricted to the Cancer Center. But surely, with all donations that come into both foundations, oftentimes the donor can kind of advise where that goes, but in some cases, it can go to, essentially general fund, right? So unrestricted. And the leadership of the foundation works with the boards of the foundations, and they generally do have comments, concerns about how those funds are used. So that absolutely can work on, just as we see in Incline, also here in Truckee. Yeah, and I'd just say one last comment on that work, because we've seen a lot of activity here in Truckee with the foundation on this side of the Brockway. It takes a lot of work to get to a point where you have a month like we've just experienced. It takes a lot of relationship building, a lot of communication, and I have to credit Carly Epstein and her team, because it's just planting seeds all the way. And they've done a wonderful job here in the back half of this year. Something to be very proud of.
I also wonder, too, it's our 75th anniversary. The story of how Tahoe Forest started resonated with so many people. I mean, I heard it outside of the hospital and other organizations about, they talk about the Joseph family and that. And so I think taking your story out to the public has really made a difference in some of that. So I hope that we can continue with stories. We'll have to figure out the next story to tell. Thank you.
And with that, on the 75th year, there was a gala this year. There was, and mark your calendars. The November 1st is the date for next year. So it was so successful, and the feedback so positive that it's already on the calendar. I think the space is reserved. So November 1st. There you go.
Right.
Nice. I believe that's it for committee reports, foundation reports. Any board member reports?
Just a reminder that AHA's Rural Health Conference is going to be in February. It's on their website, but the actual agenda hasn't been finalized. And it's an opportunity that the board is always given to attend. It will be in San Antonio, Texas this year.
All right. Fantastic. I'm going to hold for any closing remarks, and just there were no actions taken in closed session need to be reported on, I believe. But before we adjourn, ever since I've been on the board, it is tradition to close out the December meeting with former chair Alice Wong.
It's my favorite ending to a story. Merry Christmas to all, and to all a good night.
And with that, most happy holidays, happy new year. Meeting adjourned.
Yeah.